So in summary, this is a 76-year-old gentleman who's presented with a non-STEMI. He has active cancer with a surgical intervention pending. He's multi-vessel and multi-segment disease, and he's in the high bleeding risk category. So I'm going to pass you back to Javier and Hernan in the cath lab to discuss the procedural planning.
Thank you very much, Brida. So let me just park a stand that I have here, and we will continue. We'll discuss this with you in a second. So as you can see, and we are looking for your reactions very soon, this is a patient where certainly one of the important things is to perform proper planning of what we are going to do, avoid unneeded stenting, obviously, and ensure that all the stenting that you are performing is immaculate and that you have the lower dependence as possible to antiplatelet treatment, because obviously we anticipate that the patient is going to have surgery very soon. Now, the starting point, if you can show the slide that we had in the screen, the starting point for that is, sorry. Can you show the strategy slide, the previous one? Thank you. So the first thing that we consider is that we would like to first plan our procedure on a functional basis, because we have to remember stenosis in the LAD, circumflex at different level, multi-lesion level stenosis in the circumflex. And we would like to, before embarking into the case, anticipate what will be the findings that we are going to have. So Hernan is going to show you this in a second. What we plan to do afterwards, based on this information, is to perform a guidance of our procedure based on IBUS and angiography with co-registration to perform stem planning. Then we would like to use ultra-thin stents to maximize the healing response and to decrease the dependence on APT as mentioned. And finally, we will ensure that the luminal dimensions are good. So let me handle it over to Hernan. If you go to the next slide. And let's have a look to the planning of the case that we perform based on QFR.
Thank you, Javier and Justin, for this kind invitation. So, yeah, we have decided to analyze with QFR this patient with multivessel disease. And in this screen, you can see the QFR analysis of the LID. We have in this vessel two tandem lesions in the proximal and in the mid-segment. Also, there is an important stenosis or an ambiguous lesion. And here you can see that the QFR value is 0.79. So this is a borderline ischemic positive, but very close to the cutoff of 0.84 QFR. So in the same manner that we interpreted the results of pressure wire FFR. Next slide, please. So in this other slide, you can see that we can also select the lesion number 2, as you can see below at the top in the yellow marker, that the second lesion is less important compared to the first lesion. And this is a tool that QFR allow us to perform an individual stenosis assessment in case of tandem lesions. So, although overall the summatory of both lesions is borderline from the point of view of a QFR, perhaps the proximal one is more important. But in any case, considering the previous aspects that Javier and Brida have comments about this patient, we decide to defer this vessel because of the very borderline QFR value. Next slide, please.
And perhaps before moving to the next slide, can you go to the previous one? Thank you. Hernan, we did already a measurement of a physiological measurement, to confirm this. Can you show the slides? Can you show, please, the screen with the results of the IFR measurement that was performed? Okay, I will do it. Don't worry. Yeah. So the IFR measurement. So this is the IFR measurement, the co-registration in the LAD. And as you can see, it confirms that actually the stenosis in the LAD is not significant. I'm measuring now, Hernan, we are placing the measurement distal to all these diffuse disease that is here, and it does not reach hemodynamic significance. Typically, in the LAD,